Go live.
Welcome, doctors. A very good afternoon to all of you. On behalf of ITRO, I, Dr. Prashant, welcome you to this webinar on influenza and risk prevention. Today, we have got Dr. Ketan Shah and Dr. Ravindra Chopra with us to share their experiences on influenza and risk prevention. Doctor, as you know, ITRO Healthcare is an innovative pharmaceutical company providing our journey began in 1993. We have got 30 years of excellence and 3,000 plus product in our portfolio. 21,000 employees employed globally, and we are amongst the largest manufacturer of ARV, APIs, and FDFs in the world. We have Asia's largest manufacturing facility at ACZ Complex, Visakhapatnam. We are present in about 126 plus countries. Hetero Healthcare provides 360-degree solution provider. We strive to fulfill unmet healthcare needs, reach out to customers across India. Wide range of products encompassing various specialties. We are pioneers in quality and innovation. We have the distinction, doctors, of bringing 4 biosimilar products to market within 5 years of registration, like darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, we have introduced 3 antivirals, favipiravir, Covifar, and Flovir, for which we received an award of Pharma Excellence in August 2020 for COVID drugs. In today's webinar, we have got Dr. Ketan Shah and Dr. Ravindra Chopra as our speakers. Just to give a brief introduction, Dr. Ravindra Chopra is MBBS MD Pediatrics, Sir is Chief Pediatrician and Director, Muskan Children's Hospital, Surat. Dr. Ketan Shah is MD DCH, President, Surat Pediatric Association, 2003, National Trainer, ATM PSPP, ASK IAP CPIDC. How do I investigate? Rational Antibiotic Practice, National TB Module, Rapid Module. Sir has been National Secretary, Pediatric Rheumatology Chapter, 2005-2006, Organizing Chairperson, National Rheumatology B, 2006, EC Member, Gujarat Pediatric Association, 2014 and 2019, and EC Member, ID Chapter, 2013. Welcome, Dr. Shah. Welcome, Dr. Chopra. And with this, I hand over the session to the doctors. Over to you, doctors.
Good afternoon, everybody. Am I audible? Just somebody can reply me.
Yes, sir.
Yes.
Okay. Thank you, Dr. Prashant, Samriddhi, and Mr. Jain from the Hetero team. Welcome, Dr. Ravindra, and to all viewers who are seeing and listening about the oseltamivir in flu management. Dr. Ravi has been a very close friend of us, and he is very expert in the respiratory diseases also. We'll be taking his help in discussing out about the oseltamivir influenza and its prevention. The content of the talk would be healthcare challenges in monsoon and their diagnosis, influenza and its complication, the evidence of oseltamivir may be clinical and the research wise, and the guidelines and recommendation for empirical use of oseltamivir. Normally, the disease, influenza usually is more common in the monsoon. In the monsoon, we get influenza-like illness, H1N1, then severe acute respiratory illness, and COVID-19. SARI or SARI was a very famous name during COVID epidemic, and there are many differential diagnoses for SARI also. India and its flu disease, what we know about it, in which season, and what is the correct time to vaccinate. I would like Dr. Ravi to comment on this. Dr. Ravi, what we know about influenza in India and which is the season and what is the correct time to vaccinate. Over to you,
Thank you, Dr. Ketan. Yeah. First of all, thank you, Dr. Ketan, for your nice words of introduction. Thank you, Dr. Prashant and entire hetero team for arranging such kind of a webinar. Coming to the flu, so broadly, we define respiratory illnesses as like influenza-like illness. So any respiratory illness which comprises of sudden cough, running nose, throat pain or sore throat with a fever more than 100.5 with associated symptom as muscular pain, headache, fatigue, body ache, vomiting, and runny or stuffy nose. We broadly categorize all these illnesses in the term of influenza-like illness. Today we will specifically talk about flu. So we have limited database in India, but we do have a Government of India database for flu, which has been reported through this portal. And as we know that there are almost every year we get around 20,000 reported cases of influenza every year. And many of them require hospitalization and a good number of morbidity and mortality do take place. So if you talk about Gujarat, like in the last till August 31st, according to the Government of India data release, we had around 1,400 cases of influenza reported, and out of which around 32 died, which the confirmed figure from as the primary cause of mortality was influenza in these cases. So influenza is a seasonal disease basically. Though we get sporadic cases throughout the year, the influenza season is divided in two parts. India being a part of both northern and southern hemisphere. So northern hemisphere influenza is an illness of winter season, generally around in a month of maybe January to March. And in our part of the world, like in if you talk about western part in Surat and southern part, southern hemisphere, so we get influenza mainly in the monsoon season. So monsoon is a peak season for influenza from July, August to October. And similarly, the vaccination is generally northern hemisphere vaccine and southern hemisphere vaccine. And the time of vaccination is always before the flu season begins. So you should be immunized almost around 1 month prior to the season, which begins as a monsoon season begins in August. We immunize them generally around April to July. And similarly, for the northern hemisphere, it is from October to December. Over to Dr. Ketan.
Thank you, Dr. Ravi, for your nice elaboration. We'll be sharing you some data about the India and its incidence. This is 2019, which shows that gradually the peak is seen in the January to April, and again a second peak in June, July, and October. Maybe May, June is bit a quiet season, but again, throughout the year there are few cases and two peak which are seen in the month of Jan to April and June to October. These are the reported cases of acute respiratory tract infection, and the burden of the disease is too high. Hospitalization was 5,88,000, death were 26,000. So almost 1.8 per 1 lakh is the death ratio in case of a influenza-like disease. These are the year-wise data in 2017. The number of cases were 38,000, death were 2270, and in 2022, 12,800 cases were reported and 399 deaths. And this was almost up to the March. These are official data which I had taken from the Purple Book of Immunization, which is published by Indian Academy of Pediatrics. So Indian data again has been correlated as 5 to 10% of all ARI are due to influenza. 10 out of 100 child per year suffers from influenza. In two different studies, 180 to 178 per 1,000 children per year below 1 to 2 years were suffering from influenza. Influenza-associated respiratory infections were 33 to 44 per 1,000 children per year, and in 2009 pandemic, 22.8% cases of respiratory were positive for influenza. And in 2015, again we had an epidemic, and up to March 2015, 30,766 positive cases were reported and 1809 died. The August 31st, 2024, what Dr. Ravi has reported, we had a huge number of influenza disease. Northern India peak is in Jan-March, Central India July to September, Southern India September to November. So pattern of circulating strain virus also varies from one part to another part. These are the cases of influenza infection, and we can see that the number of incidents in 2019 was 28,798 and death in 2019 was 1218. So these are official figures of influenza from NCDC, Government of India. Dr. Ravi, would you like to say something about this study? Over to you.
So this was basically a seasonal variation regarding influenza. This was a 7-year cumulative study which was done by Department of Virology in Chennai, Tamil Nadu in 2019. 36,670 specimens were subjected to influenza analysis, and the duration of the study was 7 years. And influenza positivity starts with the onset of monsoon and peaks during the post-monsoon season. So this was just to know about the peaking of the influenza season. So a consecutive 7-year study was cumulative study was done to see the peaks of influenza.
Okay,
Thank you, Dr. Ketan.
Yeah, thank you, Dr. Ravi. And this is something about the epidemiology and etiology. It is one of the commonest infectious disease. It is a highly contagious airborne disease, occurs in epidemic. It can cause mild to severe illness. Serious outcome of flu infection can result in hospitalization or death also. There are three types of virus, A, B, and C virus. The currently circulating in humans are subtype A, H1N1, and A, H3N2. Dr. Ravi, there is always a talk about the drift and shift. Can you throw some highlight on influenza drift and shift? Over to you.
Thank you, Dr. Ketan. Yeah, so as Dr. Ketan has nicely elaborated about the type of influenza viruses. So influenza basically virus is classified according to the neuropeptidase and capsid protein. Capsid protein is only present in type A virus. And the subtype is basically generally in type A, the subtype is because of neuraminidase and hemagglutinates. So that's why we name it, nomenclature is given as H for hemagglutinin and N for neuraminidase. So A type is notorious for kind of a mutation. So there is a whole genome shift of the virus. So it is a new virus sometime, and that is known as shift of the virus. So whole genome sequence has been shifted, and the parent virus leads to another offspring, which is totally a new virus. So these kind of viruses, they are absolutely new virus and don't provide any sort of immunity to the host. And that's why these viruses are notorious for pandemics and huge epidemics. They can be the cause for sporadic cases as well as endemic cases also. Type B is a relatively stable virus and it has only one subtype, but there are two lineages, Victoria and Yamagata. So these are generally stable, and sometimes some strains circulate, sometimes other one, and generally there is no significant shift. Then there is a drift. Drift is basically within the genome there are small mutations. So the subtype changes, like as we talk about H1N1, then H7, H3N7. So these are the basic small mutation that does not provide much of the cross protection and leads to the seasonality of the influenza virus. So shift and drift are very important for our understanding of immunization in influenza. and hence we can, provide database for the upcoming vaccine. Over to you, Dr. Ketan.
Thank you, Dr. Ravi. See, this basic pathology or microbiology is important to know. Then only we'll be able to understand why the vaccination, strain, new strain, NH, drift and shift. Dr. Ravi has very well highlighted about the meaning of drift and shift. Transmission of flu virus, it's very notorious. Even on 6 feet distance, it can spread. It spreads mainly by droplet. Droplet can land in the mouth or noses of people, or even by handshake also. So people should stay away. I would say that the COVID protocol should be maintained to prevent the spread of the disease. Mainly, children may pass the virus for longer than 7 days, even if they are asymptomatic. An adult can spread the disease like anything. This is some differential clinical presentation of influenza-like illness, H1N1, SARI, and COVID-19. Clinically, sometimes it is difficult, but H1N1 would have a more breathlessness, severe acute respiratory would have a more breathlessness, COVID-19 would have a more breathlessness. Loss of smell and loss of taste is with COVID-19, but even me and last time Dr. Ravi has also said that even in H1N1 we get loss of smell and loss of taste. Diarrhea can occur in COVID-19, even in H1N1 also. Severe myalgia is very common in these type of respiratory diseases. So any patient coming in the clinical practice with high fever, sore throat, myalgia, maybe complaining of loss of smell or loss of taste, कि सर बिल्कुल खाता नहीं है और उसको चटपटी चीज ही चाहिए खाने की, तभी उसको टेस्ट आता है. This may be a pointer towards H1N1 or COVID-19. In the present scenario, we get few cases of COVID-19, but the primary etiology in this epidemic or in this season is H1N1 only. Dr. Ravi, can you just enumerate this slide? What are the clinical spectrum of the disease in influenza-like or influenza disease? Over to you.
Yeah. So if we talk about clinical spectrum of the influenza-like illnesses, or mainly talking about influenza, it is a varied presentation. So there are multi-systemic involvement in the form of respiratory symptoms, maybe from starting from the mild cough and coryza to the severe respiratory distress like ARDS, sepsis-like presentation. Then we can have some time presentation with encephalopathy and a severe illness, severe hepatic encephalopathy-like presentation, especially those who are on aspirin therapy, that can present in the form of Reyes syndrome, especially those like Kawasaki disease or rheumatological diseases who are already on aspirin therapy. Then at some of the at-risk children, like children of chronic respiratory diseases, diabetes, heart disease, it can have a devastating course. Especially also similarly in immunocompromised hosts, those who are on steroids, those who are having primary immunodeficiency. So if you talk about the course of disease, generally we divide the disease into three categories. Category A, B, and C. The general A category A is a milder kind of illness with mainly cough, coryza, and mild fever. Type category B is a generally severer version of the category A with high fever and severe throat pain, or with some comorbidities like, for example, any associated chronic respiratory illness, chronic renal disease, heart disease, diabetes, or like if we talk about rheumatological disease, immunocompromised kids. So these all are type B. Type B is basically uncomplicated severe disease. And type C is a severe disease which requires compulsory hospitalization and close monitoring, which can be in the form of respiratory distress, shock, sepsis-like presentation, and for example, other associated like encephalopathy, Ray's syndrome. All these comes into category C, and which all of them require hospitalization. Thank you, Dr. Ketan.
Thank you, Dr. Ravi. So influenza is not only respiratory, it can affect all system, and especially in neonate or the early infancy, It can come as a sepsis-like syndrome where you may not have a classical respiratory finding. And the high-risk category, what Dr. Ravi has rightly mentioned, immunocompromised and on aspirin. So the warning signs which we all should know for any disease, but for respiratory in children, fast breathing, what we learn in the PALS course, A, B, C, D, E. If airway is compromised, if breathing is fast, if tachycardia is there, child is cyanosed, not waking up, altered sensorium, these all are signs of serious disease. And even in the adult, when you have a dizziness, confusion, altered sensorium, respiratory distress, hypoxia, low oxygen saturation, these all are warning signs for any of the disease. And in this situation of or in epidemic of respiratory illness, beware, this could be a influenza, serious influenza disease. Dr. Ravi, can you highlight about what are the diagnostic tests available and complications already you narrated, but about the diagnostic test? Over to
Yeah,
you.
sure. Sure. So, generally, WHO approved diagnostic tests are only three. One is a subtypable RT-PCR, second is viral culture, and third is a fourfold rise in the titer of influenza antibodies. So, unfortunately, these all of them can be sometimes difficult and cumbersome to get and may not be available everywhere. So, most commonly used test is generally the RT-PCR, maybe non-subtypable or subtypable RT-PCR, which we commonly use. It's a nasal swab, basically, and we get the result in around 3 to 4 hours. Then there is availability of rapid antigen test also in some places, though it has not been standardized and not very authenticated. But the common diagnostic test which everybody should use is a typable or RT-PCR test approved by a WHO laboratory. And talking about complication, we have already discussed about the respiratory and non-respiratory complication. I think we can go ahead.
Okay, thank you, Dr. Ravi. So in summary, we can go ahead with RT-PCR test, which is the standardized modality of test, but it is a bit costly test. So maybe point of care or point of test, it may not be a sufficient. We'll just have a highlight about the complications of flu, which we already discussed. Respiratory infections, CNS involvement, pneumonia, SARI, and worsening of the existing disease. And patient may end up into the ARDS also. Management of influenza. Treatment of influenza is basically supportive for category A patient, which Dr. Ravi has already mentioned as A, B, and C category. For a minor symptoms, it's a bed rest, fluid consumption, cough suppressant, antipyretic, and try to avoid NSAID because sometimes it can create a trouble. Most patients with influenza recover in 3 days. However, malaise may persist for weeks. Severe cases may require monitoring and sometimes hospitalizations. The modality of treatment, there are two varieties of drugs, neuraminidase inhibitor and adamantinase or M2 ion channel blockers. Normally, we are very familiar with oseltamivir, which is a neuraminidase inhibitor, and zanamivir. Oseltamivir has been frequently used. Amantadine and remanatidine are not very well proved. They are active against influenza A virus, but a very well studied drug is oseltamivir. Dr. Ravi, can you highlight, do we get cases? Just a very short answer. Do we had the cases in these last 3-4 months? Over
So
to you.
yes, Dr. Given, yes, we do get influenza cases once we suspect. So because the clinical presentation is so varied and it is not possible to confirm all these cases, but we do get clinical presentation like of influenza-like illness, and many of them who are in category B or category C, we sometimes have to get them investigated, and we do find uh, uh, type of influenza virus. Actually, in August, generally we had a lot of cases of type A influenza, And lately, in the last month, we had lot of cases of type B influenza. It is not possible clinically to differentiate between A and B, but we do get cases, and maybe not that severe all the time, but sporadic cases do happen most of the time, and there are some peaks. So sporadic peaks are there, which we got probably in the last month and then in the month of August.
Yeah, I do agree with
Okay.
Dr. Ravi. Even in ICU setups in Surat, we had so many ARDS or respiratory, like illness, and their influenza was positive in good number of cases. So we get so many cases of influenza during August and September. Dr. Ravi, we would be having some rapid fire questions over to you, maybe like
Yeah,
playing
sure.
KBC. You will have no helpline. This is your answer only. Infant, 2 weeks, history of fever, cough, cold, family history of cough, cold, and fever, adult admitted for acute respiratory. What should be your line of action? Over to you.
So, if you talk briefly about this child, this is a young child, 2 weeks only, and symptoms suggestive of influenza-like illness with a certain family history, so which also points towards a flu-like illness. And the adult might or might not have been investigated for influenza, but all picture falls in influenza-like illness. And considering the young age of the child, this child definitely requires antiviral therapy along with the supportive treatment, isolation, and a very close monitoring for the worsening, because these are the kids who can worsen very fast and present in severe respiratory distress. So I would treat this child with antiviral or siltamil therapy.
Very nicely elaborated, Dr. Ravi. But I have a doubt. Such a small kid, parents would be worried for the side effect of oseltamivir. Do you think that oseltamivir has any side effect, or we need to monitor about it? Over to you.
So generally speaking, oseltamivir is a very very safe drug, and the safety has been proven through multiple studies, even in infancy in young child, and it has been recommended in a child as low as 3 kg weight. So, and in my practice also, I've used in some of the kids in such young age group, and I haven't encountered any serious side effect. Generally speaking, it's a very safe drug and does not require much of the monitoring.
Yes, Dr. Ravi, I do agree with you. Oseltamivir is one of the safest drug, except mild diarrhea. There are no other hematological or CNS side effect. So empirical use of oseltamivir in this group of children is very well justified. Without diagnosis also, in this clinical scenario, we can start the oseltamivir. Dr. Ravi, 5 years, walk-in patient, mild fever, myalgia, cold cough, healthy child, no family history of ARI. What would be your plan of treatment? Would you like to start oseltamivir here?
So
Over
yes,
to
no, oseltamivir is not recommended in this child. If your child is around 5 year or more than 5 year with mild symptom, even if it is a influenza-like illness, it is coming into category A and does not require any specific antiviral therapy.
fine, that's good. I think you have earned almost 1 lakh rupees by answering two correct questions. Third more question. 9 years, known case of asthma, fever, cough, running nose, not very sick, and there is a family history of acute respiratory infection. Should we start antiviral? Over to you, Dr. Ravi.
I think we should start antiviral therapy because we don't, in this scenario, we don't know the severity of asthma. If it is a chronic allergic asthma and presenting with this kind of a symptom, and especially during the monsoon season where we have a peak of influenza, these kids can either get severe asthmata, acute asthma, or they can have a severe influenza. So, along with the supportive treatment, we should start antiviral therapy.
डॉक्टर रवि हमारे कॉम्प्यूटर जी ये पूछ रहे हैं कि डे 1 और डे 5 ऑफ इलनेस शुड वी स्टार्ट एंटीवायरल ओवर टू यू
Earlier the better. Earlier the better. So, the antiviral therapy is best suited if we start within 48 hours. But even if it is delayed, the benefit of doubt should always go to the patient. And even we should not be deferred by a late start of the therapy. So it may not give uh, exact improvement as we expect in first 48 hours, but of course it will be helpful.
Yes, yes. That's very nicely elaborated answer. Oseltamivir, safety, early to start. If you are late, then also you should start because it is one of the safest drug and asthma is one of the high risk for influenza-like illness. A known case of nephrotic syndrome on steroid, not vaccinated, with acute respiratory, may be category A. What should we do? Should we start or not? Over to you.
So that Ketan, this patient, if develop influenza-like illness, it will automatically be the category B. So it is basically category B plus, and whether we test or not, we should start antiviral drug in this child.
Very rightly said, Dr. Ravi. We'll go to the one more question. 3 years, healthy child came with ARI, symptomatic treatment given better. Fever reappeared after 5 days. Coughing increased. X-ray bilateral infiltrate and possibly right upper zone consolidation. Can you analyze this case and give a guidance to the viewers?
Yeah. So this case actually represent either one of the two possibilities. One is that the child was having to begin with having influenza and has appeared with a secondary bacterial infection. So secondary pneumonia, as we discussed, and one of the complication of influenza. So either the child has developed a secondary pneumonia, or it can be a long influenza illness itself. So influenza can have two peaks: initially lingering course and then worsening in the later part of the illness. So this is either of them, and both in this condition, we will definitely require antiviral therapy along with supportive antibiotics. So this is where the role of antibiotic comes in influenza.
Uh, Very rightly said, Dr. Ravi. It is very important that this could be post-influenza, maybe immune-mediated ARDS or superated bacterial infection. And sometimes it's difficult to prove it. So antibiotic and antiviral both are justified. Dr. Navi, 9 years, fever, myalgia, mild cough. On day 3, difficulty in walking, calf tenderness, what it is, and is there any role of antiviral in this situation? Over to you.
So this child basically typically the older kid who gets influenza-like illness with lot of myalgias. So in these cases, myalgia may be associated with symptom of influenza, but sometimes it can be immune-mediated also. So these myalgia does not indicate the severity of influenza infection, and it is not falling into high risk category. So I think there is no role of antiviral in this situation, and only the mainstay of the treatment is hydration of the child. So plenty of fluid, maybe sometime if it is a very severe condition, maybe we have to give IV hydration, but no antiviral in this situation.
Yes, so this is the rationality of using antiviral in given scenarios of influenza-like illness. So this is something about oseltamivir, potent and selective inhibitor of the neuraminidase enzyme of the influenza A and B. It is a prodrug which is converted into oseltamivir carboxylate in the liver. It inhibits influenza virus replication and its pathogenicity, prevents further spread. It is effective against all strains of A and B, especially swine flu also. This is how it works. Picture depicted that it works on the various viral particles and prevent its spread. So it was the first oral neuraminidase inhibitor. It is approved in more than 100 countries. Approval by FDA, CDC, and American Academy of Pediatrics also. The dose you need to remember, less than 15 kg, it's a 60 milligram per day divided twice daily. 15 to 23 kg, 90 milligram per day. 23 to 40, 120 milligram per day. More than 40 kg, 150 milligram per day. The suspension is a 12 milligram per ml. So 2.5 ml, 3.75, 5 ml, 6.25, and 0.25. The chemoprophylaxis to the surroundings or the family member, the dose is once a day, and this can be remembered or you can store it in your mobile and whenever patient comes, it can be given. The recommended duration for post-exposure prophylaxis is 10 days, and the recommended duration for community outbreak is almost 6 weeks, or maybe up to 12 weeks in immunocompromised patient. And the treatment should be initiated as early as possible. There are benefits of empirical and early use of oseltamivir. It's a wonderful drug for walking pneumonia and early onset fever symptoms. Like we had one case, 5 years female, patient had a complaint of high-grade fever, sore throat, severe coughing, myalgia, body ache. She had a breathlessness, vomiting and diarrhea. Her body was flushed and child had respiratory findings with distress. Child was admitted. This is a case history 15 days back. It's a real case scenario. CBC and CRP were normal and child was started on supportive treatment and oseltamivir. This is the X-ray which is showing mid-zone involvement with bilateral infiltrates, which is highly suggestive of influenza-like illness. This was done on 25th of October. And this patient recovered within 2 or 3 days. Sometimes there are studies which shows that the empirical use of antibiotic along with oseltamivir may be helpful. But if you have a classical diagnostic modality available, then probably oseltamivir is a better drug, and it prevents the misuse of antibiotic. It prevents the influenza-related hospitalization if you start it early. The severity of pneumonia also reduces because of H1N1 if you start oseltamivir earlier. This is the study depicting that if you start oseltamivir early, the chances of hospitalization reduces. Early recovery is better if you start empirical oseltamivir. So basically, it's a good drug. This graph also shows that probability of severe pneumonia reduces if you start oseltamivir early. Again, same picturization that if you start early, days of hospitalization also reduces. So guidelines and recommendation by majority of the authorities, WHO do recommend high risk group, early onset, early treatment, empirical treatment, and sometimes the test may be negative, but that does not exclude the H1N1 disease. These are by the government of India, which also says that empirical therapy includes oseltamivir-like drug for treatment of influenza when there is a local circulation or other risk factors. So recommendation is also there by various authorities in community-acquired pneumonia, in adult patient also. If you start early, then probability of getting complication reduces. So these are the study and its recommendation. So in summary, proper diagnosis can and early treatment can prevent flu complications. Empirical use of oseltamivir reduces lower respiratory tract complications, hospitalization, and antibiotic use. WHO, American Thoracic Society, and Indian government recommends empirical use of oseltamivir. Thank you so much. Thank you, Dr. Ravi and the Hetero team for giving us this opportunity. Over to you, Dr. Prashant.
Thank you. Thank you for this wonderful presentation. I have a couple of questions. One is, in which age group, patient age group, does oseltamivir prophylaxis is the best, gives best results?
Dr. Ravi?
Yeah, so the oseltamivir prophylaxis is one of the areas of controversy now, because since we have a lot of sporadic and endemicity of the influenza virus, there is a hue and cry about the resistance of oseltamivir, developing resistance to oseltamivir. So, to protect this drug, there are different guidelines and recommendations for prophylaxis. But definitely, in severe outbreaks, we do recommend prophylaxis. And younger the child, especially less than 5 year of child, we do recommend prophylaxis because then the child generally have a severe influenza-like illness. Or in the geriatric population, if one has a old age grandparents in the house, and then the patients with comorbid conditions like if somebody has a patient with chronic heart disease, diabetes, etc. So some comorbid conditions, personnel who are coming into contact with influenza patient, they should definitely receive prophylaxis. But I'm a little skeptical about using to all the population coming into contact with the child.
How common is the resistance with oseltamivir? Have you seen any resistance?
I think we
So
don't have
in
about it, but we are a bit worried also
Yes,
because of
correct.
frequent use as well as the
Correct.
high incidence. We don't
Correct.
have any, I think Dr. Ravi, you will also,
Yeah.
we don't have any studies to
yes,
say that it is resistant. But for prophylaxis, I do agree with Dr. Ravi. What we discuss is a high risk category. If there is a patient and the surrounding or a family members, high risk category, including geriatric patient, they all should receive the prophylaxis.
Prophylaxis.
And if any person, healthcare personnel, or if there is a huge epidemic, in person is moving out of the society, out of the house, then also he can take it for 6 weeks to 12 weeks.
Correct. Well, thank you, doctors. Thank you so much for this wonderful presentation. A lot of insights we got on influenza and its management, especially also with oseltamivir, and the do's and don'ts that we normally, just somehow miss and then land up in complications. Lovely. Thank you both of you for this wonderful presentation, and thanks all the doctors who time from their busy schedule and attended this webinar. Thank you, Hetero Marketing team, for conceptualizing. Thank you, field personnel for Hetero for super coordination. And last but not the least, thank you, IT team Hetero for IT support. Thank you, all of you. I wish you all a very good afternoon and signing off. Thanks, Doctor, once again.
Thank you.
Thank you.
thank you, Dr. Prasad.
Thank you, Dr.
Thank you,
Ravi.
Dr. Ketan.
Thank you.
Bye-bye.
Thank you, sir.
Bye.
Okay, Samriddhi, bye-bye.
Bye, sir. Thank you.